North Idaho College, in cooperation with KSPS TV, presents Earth in Crisis, a search for solutions. Highlights from the 38th Annual NIC Popcorn Forum. The 2008 symposium featured guest lectures and public discussion on 5 critical issues facing the world today. This is Episode 2, Emerging Viral Diseases, a World Crisis.
I wish to welcome you to the second of 5 one-hour documentaries titled Earth in Crisis, A Search for Solutions. On this second documentary, our subtopic is Emerging Viral Diseases, a World Crisis. Our featured individual on this particular documentary will be Dr. Kenneth Alexander, an MD and PhD who teaches at the University of Chicago, and he shall be joined in the documentary by a number of other panelists who are experts in the field. Thank you for being with us on this documentary.
So the topic today, we're going to talk about emerging viral diseases. And there's a couple of reasons to talk about it. One, because it's just interesting. 2, it fits in with the theme that we're discussing today, which is how changes in the environment affect infectious diseases. Perhaps one of the most important reasons, though, is for those of you that are students here, this gives you something interesting to talk about when you go home for Easter break, right? Grandmother's going to ask what you've learned, and you can talk about Hanta and Ebola and bird flu and all sorts of interesting things that I suspect are much more interesting than talking to Grandma about a canoe condensation or whatever you're covering in organic chemistry right now. So, when we talk about emerging viral diseases, this is often the image that comes to mind right here, right? It's the folks in the fancy suits, and we're trying to figure out what's going on and what a tremendous mystery this is. And the fact that you see this picture on the cover of Parade magazine tells you that this is something that has really caught the national interest. And it's caught the national interest for a couple of reasons. 1, because this is just interesting science. 2, because this relates to biodefense. And 3, I think this is a marker for our increasing sense of globalization. Now, I don't know if young people nowadays read the book The Andromeda Strain. This was Michael Crichton's first big novel. And this was a story about a virus or some life form that came in from outer space on a satellite that crashed. This is not, however, what we're talking about today. This is not what emerging infectious diseases are. And this is one of the places I want to begin, is we're going to describe just what emerging diseases are and are not. So we'll begin with a definition. And really the definition that we're going to use is that emerging infectious diseases are diseases that we are now seeing or have come to our consciousness that have not been there before. Now, not been there before in our consciousness, but have been there on planet Earth, maybe for a very, very long time. Indeed, if you look at a map of emerging infectious diseases, and I think this was a clip from Scientific American, you can see here all sorts of things. There are lots of new diseases that aren't really new. They've been here for a long time, but because of changes in ecosystem, because of changes in human behavior, and because of advancements in scientific understanding, we are perceiving these as new problems. Now, where do you learn this stuff? Well, one of the neatest places to learn about anything in epidemiology is a very exciting journal. How would you like to catch this for a title? Morbidity and Mortality Weekly Report. Right? Really what this is Cosmo for epidemiologists. It's pretty exciting stuff. This is a weekly report from the Centers for Disease Control that is, in short, our nation's report card. And it is in MMWR where we learn about the initial reports of what is ill about our nation, be it motor vehicle accidents, be it adolescent suicide, be it the emergence of SARS, HIV, what have you. MMWR is available online, and in fact, it really is very interesting reading. And so as we go through the talk, Rather than tell the story myself, what I'd like to do is share with you some excerpts from some initial MMWR reports so that you can hear kind of firsthand what the company or what the country learned as we dealt with some emerging infectious diseases. So the first one is entitled Outbreak of Acute Illness, Southwestern United States, 1993. It reads as follows. Beginning in May 1993, cases of acute illness characterized by fevers, myalgias, headache, and cough. Sounds like flu, doesn't it? A lot of people have been doing that the last couple of weeks. Followed by rapid development of respiratory failure, have been reported to the New Mexico Department of Health, Arizona Department of Health Services, Colorado Department of Health, and Utah Department of Health. This report presents preliminary findings from an ongoing investigation of this problem, which suggests this illness is associated with a previously unrecognized Hantavirus. A week later, another report from the CDC. Because the findings of this investigation have suggested a role of hantavirus infection, the surveillance case definition has been revised. A confirmed case is now defined as unexplained adult respiratory distress syndrome, so again, lungs filling up with fluid, or bilateral pulmonary interstitial infiltrates, or prodromal syndromes who occurred with onset during 1993, and laboratory evidence of hantavirus infection. Through June 15th, 7 confirmed cases of hantavirus have been identified. 4 of these case patients have died. Of the 7 case patients, 4 were from New Mexico, 2 from Arizona, 1 Colorado. So what was this virus actually doing? Well, hantaviruses cause hemorrhagic fever. What is hemorrhagic fever? This is important to know because this is a common theme among emerging viral diseases. Many of them are hemorrhagic fevers. Hemorrhagic fevers do this. They attack the lining, the inside of your blood vessels. And by damaging those cells, they lose sort of the non-stick qualities that the inside of your blood vessels have. So in many ways, it's a little bit like when your mother-in-law comes to your house, doesn't wear glasses, and scrubs the Teflon off your fry pan, right? It takes off the non-stick surface, and then things start to stick. But when it happens in your bloodstream, what starts to stick are your platelets, right? The small cells that are responsible for clotting, and your coagulation factors. And so all of a sudden you're using up all your coagulation factors and your platelets, sticking to the inside of your vessels, and so you lose the ability to clot and you bleed to death. And so this is what these viruses do. They cause intense inflammation. Now, hantaviruses can cause inflammation in different vessels. The sin nombre hantavirus seems to have a predilection for attacking the blood vessels in the lung, pulmonary vasculature. It turns out, though, that other hantaviruses previously described had a greater predilection for renal vasculature, the blood vessels in your kidneys. But no matter where it's attacking, by destroying the lining of the blood vessels, you end up with a state called disseminated intravascular coagulation. And so you start choking off your small blood vessels, blood doesn't get to go where it's supposed to be going, and then you use up all your clotting factors. And as a consequence, these patients then start to bleed and go into shock. Where did it come from? Well, that was an interesting question. When the folks from the CDC went and spoke to officials in the area, and especially elderly Indian tribal leaders, they were told, we see this. This happens. It's happened before. And we see it in years when we have a particularly wet spring. The current theory is this. There was a mild winter and a heavy spring. And as a consequence, there was an increase in the rodent population. I've already told you that the rodents carry this virus, the white-footed deer mouse. So as the number of white-footed deer mice went up, the possibilities of humans interacting with these mice also increased. And so you had an increase in human exposure to what is normally a mouse virus. This is a picture of a white-footed deer mouse. So it's hard to imagine that this cute little character can carry something as nasty as the sin nombre Hantavirus. So Hantaviruses are really a zoonosis, which is to say a viral infection which is normal in animals and not normal in humans, but occasionally gets transmitted to humans. Rodent source, again, the white-footed deer mouse. In mice, it causes an asymptomatic infection. It doesn't make mice sick. They acquire it as they age, and they excrete the virus in saliva and in their urine. Doesn't make them sick, but if a human comes into contact with that saliva or urine, it can make the human sick. So let's move to another story, and we'll look for some parallels here. Just like hantaviruses, Ebola viruses are not new. Ebola viruses have been recognized in Africa for a long time, and these are just some of these dots indicate some of the known Ebola virus outbreaks that have occurred over the past few decades. Turns out there are many hemorrhagic fever viruses, and they have properties that we should talk about for a minute. Bunya viruses, you've heard of Rift Valley fever, flaviviruses, yellow fever, and you're going to hear more about dengue in the years to come. Rna viruses, and then the filoviruses, Ebola and Marburg. Again, humans are not the normal host. We're not sure where this virus came from. People believe that the index case may have come from a man who found a dead monkey of some kind in the jungle and took it home to feed his family. And in the process, got infected with Ebola viruses. Many of the hemorrhagic fevers involve arthropod vectors. We talked about yellow fever, and arthropods, particularly mosquitoes, play an important role in the transmission of these viruses. Let's talk about the biology for a minute. One reason that these viruses are so effective is because they are highly adaptive. These are negative strand RNA viruses. What does this mean? First of all, we'll talk about why negative strand is important. Negative strand tells you that there's one strand of RNA. So as opposed to you and me, where we have double-stranded DNA, this virus has a single strand of RNA. So in some ways, what we have is our genetic information and a backup copy in the complementary strand. When you have a single strand of genetic information, you have a much higher rate of mutation. And so this makes you very adaptable. The other thing is that these viruses are RNA viruses. The reason that RNA is important, well, it's this. You and I, our genetic information is DNA. DNA is very stable. Right? You hear stories about people isolating DNA from mummies and sequencing it to know about the genetic information on King Tut. Right? You can sequence a mosquito in amber and make a whole movie about remaking dinosaurs. RNA, on the other hand, is very unstable. If you work in a laboratory on RNA, right, you wear gloves all the time, you use sterilized water, and if somebody walks in the lab and sneezes, you've lost your RNA. So it's very, very unstable. So, what are the takeaway points? What do I want you to remember? Number one, most emerging diseases are not caused by new organisms. They're not some dangerous new mutation. Instead, what they are viruses or bacteria or some other organism that have gained access to an otherwise susceptible host. So it's not new, it's something that's already there that's gained access to us. Most emerging viral diseases are zoonoses. They don't normally infect humans. They infect animals, and we are accidental hosts. Most zoonoses have inefficient human-to-human transmission. Right? Even Ebola, where it was getting transmitted between people, it turns out it was being transmitted because people didn't have access to things like gloves and gowns. And so they were being exposed to virus in body secretions. And this is what led to transmission. Emergence of these viruses often seems rather complex, But in many times, many cases, we often find a cause. These viruses are often highly virulent. Now, at that point, we've got to say, well, if they're highly virulent, we recognize them. If they're not particularly virulent, right, if a new virus does nothing but cause a runny nose and a sore throat in daycare-age kids, you're never going to detect that because it's hard to pick out of the background. But as a rule, what we recognize tends to be highly virulent. And the course of outbreaks is often self-limited. And they go away for reasons that we rarely figure out. So let's talk about population for a minute. Right? The population of our planet has just crossed the 6 billion mark. And much of the growth is occurring in the developing world. Simple biology. What happens to the rate of disease as a population increases? It goes up. And so this is what we have seen and will continue to see. As our population increases, the laws of nature dictate that we will see more emerging diseases. And so this is why it's particularly important to get your humans spayed and neutered. Again, agriculture, especially as we move into places like rainforests and savanna, ecosystems that have been in balance, and we go in and we disturb that balance, and all of a sudden we've got rodents and this kind of thing that are flourishing. Water. This is the Aswan High Dam. Now, nobody can negate the importance of the Aswan High Dam in development in Egypt. But one of the things it did is it provided irrigation, was that it also provided space for mosquitoes. And with mosquitoes, we saw the emergence of Rift Valley fever, which primarily infects herd animals, but occasionally will infect humans. Urbanization contributes to disease. Because, of course, with urbanization, you've got crowding. With crowding, you have disease. And with urbanization, you have garbage. And with garbage, you have rats. And, of course, it was rats that underlied the great plagues of Europe. And rats today are still a problem. So where there is garbage, there are rats. Travel, transporting sick people, transporting livestock, and certainly movement of arthropods. And along with that, commerce. Right? There's the outbreak of Ebola virus in Reston, Virginia, where primate species were being brought in. And it turns out that some of these primates had Ebola virus and managed to expose and infect a couple of animal workers in the Reston facility with what was fortunately a non-lethal Ebola virus infection. And then as we change our climates, rerouting of bird migrations, because of course many mosquitoes feed on birds. And so with that, we are moving viral infections around to places where they have not been before. And lest we forget warfare, right? Plague, pestilence, and warfare. Those three words go together from well before biblical times, because you have refugees. And of course, one of the main killers in any war, Civil War, First World War especially, were not guns and bombs, but disease. And this continues to be a problem because you've got mass movement of groups of people. So I'll end with this comment. This is an interesting wood print. This is the ghost of Christmas present, and this is Ebenezer Scrooge. And remember, toward the end of the ghost of Christmas present's visit, he opens up the legs of his skirts, and he tells Scrooge this. He says, "This boy is ignorance, this girl is want. Beware them both in all of their degree, but most of all, beware this boy. For on his brow I see that written which is doom, unless the writing be erased." So in many ways, I think our most important tool against emerging diseases is somewhere between our heads and our hearts, right? That we have to reach out to the world, we have to be environmentally conscious, and we have to be smart. We invest up front in our healthcare infrastructure and our scientific infrastructure, And then when it strikes, we reach out in our compassion to people and help them deal with it. Finally, for those of you that are thinking about a healthcare career, I'd like you to think real hard about public health. This is an exciting time in our field. There's lots of new challenges coming up. It's a big and exciting world out there. And speaking as an infectious disease guy, this is sort of the one time that I know of where the geeky infectious disease guy gets the hot babe at the end of the movie. Thank you guys very much.
Looking at this skin infection, there's nothing about this infection that screams Mrsa to me, okay? So you can't tell just by looking at a wound, looking at a skin infection. There's nothing about this that tells me that this is Mrsa, okay? There's really not anything for me to culture, okay? There's no draining fluid from this wound. Okay? He has a central area of redness on the right side of his abdomen and then 2 other red dots above. Too often, I will hear that someone, whether it's another physician talking to me or a patient talking to me, too often someone will tell me that they've had a spider bite. And this is not a spider bite. To me, now, if I hear the term spider bite, it's Mrsa until proven otherwise. That's how common Mrsa is. So nobody ever brings me a spider. Nobody ever sees the spider. But yet they believe that they've been bitten by a spider. I rely on the history. The history is very important for me when I evaluate patients. This is this person's second episode. So if I have a person who's had repeated episodes of skin infections, then that's a clue to me that I need to raise my antenna that maybe Mrsa is a possibility here. Again, there's nothing for me to sample on this infection. So how do I prove if this is Mrsa? This person is not sick enough to be admitted into the hospital. So I usually will try to treat this in the outpatient setting just with oral antibiotics. But I have to be careful about which antibiotics I choose in treating skin infections, especially when the Mersa diagnosis is a possibility. The CDC has put out 6 C's regarding Mersa. And the first one is contact. Mersa is transmitted by contact. I don't really think of it as spread through the airway, okay? Is it possible? I would say that it would be possible to acquire Mrsa from, if they had a Mrsa pneumonia and they actively coughed on your face within 3 feet, I suppose that would be a small chance that you could acquire Mrsa that way. But for the most part, it's transmitted through hand contact. The second C was cleanliness. Daily bathing is important. Patients with a compromised skin integrity. Usually, patients will have some break in their skin for them to have a problem with a skin infection. So a cut, a pimple, it doesn't take very much for bacteria to get in and cause a bigger problem with the skin infection. The fourth C was contaminated objects, surfaces, and items. I don't think that this is a big problem in terms of acquiring Mrsa, but we take appropriate precautions for hospitalized patients. When I have a Mrsa patient in the hospital, there are guidelines of appropriate contact precautions. So people entering the room, we will have them wear, and we did bring a sample of a gown and glove when patients, families, and medical people, as they care for the patient, we have them gown and glove. The fifth C, crowded living conditions. would be a risk factor. When we look at some of the outbreaks, specifically in prisons, jails, athletic facilities, sporting teams, close contact sports, in some of those settings, there are shared towels, shared personal items, and I think that touches on the fourth bullet there. And then the last C is capsule exposure. And what the CDC was referring to was just antibiotic exposure. Antibiotic pressure, the more, and this is a highlight for me, if I have a patient who has recently been on 6 courses of antibiotics in the last year for sinus infections or bronchitis, something along those lines, then why is this patient continuing to have problems with infections, and what antibiotics have they been exposed to? So the greater number of courses of antibiotics, that's when I get more concerned about the possibility of Mrsa. It's also a point that patients who come to their physician, we touched on viral infections this morning, and patients who come to their physician, to the urgent care, to the emergency department and request antibiotics, it's a fine line between asking for antibiotics for a bacterial infection, which we will be able to treat, but then when we look at a lot of these upper respiratory infections, common colds, are caused by viruses, which the antibiotics won't have any effect on. So we want to make sure that we're absolutely needing an antibiotic, 1, before you request it, and 2, from the physician or the provider that's providing the antibiotic, is it going to do any good? I've already mentioned that we have some limited options for the treatment of Mrsa. Now, this is not a slide for, I don't really want you to copy down the names of antibiotics that we use to treat Mrsa. That's not my intent here, but Mrsa is resistant to some of the usual antibiotics. But my point is that we have other options. We don't, if someone comes into the emergency department and they find out that they have Mrsa, and immediately they panic. Immediately they have concerns about, where did I get this? How do I get rid of it? And they're concerned that the infection is going to eat their arm off because it's going to be this advancing infection. And that's not the intent here. I want to reassure you that we do have treatment options, okay? And this is a list of some of the treatment options. Doxycycline and sulfa are oral antibiotics that we can use. Vancomycin, daptomycin are some IV antibiotics that we can use. Linezolid is available both orally and intravenously. And the last 2 items I just wanted to throw out there, that these are 2 antibiotics that will become approved. So there is new research being developed to identify new antibiotics that can be used for the treatment of Mrsa. What can we do in terms of preventing infection? And what it comes down to, the primary message is that we need to be good about hand washing. There's lots of different products out there that you can use to wash your hands with. One of the items that I use in my office and we use in the hospital is an alcohol-based hand gel. These hand gels are very convenient. The important thing to know about these hand gels is that you need to make sure that there's at least 60% alcohol in the hand gel. We have dispensers that are mounted on the wall outside of every patient room, and so it's easy access for medical people and patients families to use those before and after visiting. And it's one of the things that's helpful in not only preventing the spread of Mrsa, but other types of infections. Bactroban is a topical antibiotic cream. The generic name is mupirocin, and this is a cream that we can put on local wound infections for Mrsa. Hibiclens soap is a liquid soap that I'll often prescribe. It's not a prescription soap. It is available over the counter. The generic name is chlorhexidine, and I will have patients use Hibiclens on a daily basis in the shower to help try to get rid of Mrsa. I emphasize no shared towels, razors, brushes, or any other personal items if patients do have Mrsa. And I'll often recommend environmental cleaning of the home. And what does that entail? This is a difficult thing to do, but what I emphasize is the use of bleach. It's a 1 to 10 bleach solution in a spray bottle, and I just have people spray high traffic areas. So what are high traffic areas? I have them hit the refrigerator door handle, faucets, sinks, countertops, high traffic areas. Okay, and then the last bullet is just hand washing, hand washing, hand washing, and hand washing.
Dr. Alexander and the other speakers have talked about the CDC. The CDC every year looks at the emerging influenza outbreak and creates guidelines as to who should be vaccinated and when. Usually the guidelines for the influenza would be that you want to try and first hit those that are most at risk for serious complications or even death, and that's small children under 5 and the elderly. So those are the first people you want to get vaccinated. And then your healthcare population, because you want to keep your healthcare population, healthcare workers healthy so that they can take care of people. You want to get the people with chronic illnesses. And then last of all, you would target healthy, relatively young people. They may still get the flu, but they're going to do okay with it. They'll be sick, they'll be miserable, but they're generally going to do okay. So if there's a vaccine shortage, those are the last people you would vaccinate. Well, what's happened in the last few years is that large retail companies have figured out that they can perform both a public service and get great marketing value out of providing vaccines on a mass scale. So the Walmarts and the Rite Aids order huge quantities of vaccine, and in order to do their little vaccine clinics in their stores. It does get the vaccine out there, but one of their major goals is to bring people into their store. And the problem with it is that it completely circumvents the guidelines. Because who goes to Walmart? Or who's going to be there is not likely to be the elderly with the chronic illnesses or even the little kids. It's the people that would generally be the last ones you would vaccinate, the healthy people up getting around. But they order such huge quantities of vaccines that the physician offices often don't get them or get them so late that it's too late sometimes to vaccinate the population, to cover their own patients.
I think this has been a wonderful discussion, and I think there's some comments well worth emphasizing. It's especially as I look at my talk, one of the things we began with was the idea that we're talking about things you're not going to see, and yet everybody here, and especially Dr. Dixon's talk, has spent quite a bit of time on influenza. You realize that influenza this winter in the United States will kill somewhere between 20 and 30,000 people. I think that's even more people than are dying in the war on terrorism. And so one of the things we have to keep reminding ourselves is that this is an enemy we know, and it's an enemy we must not forget. So I think that's a particular important point. Dr. Souvenir also brought up some interesting points about methicillin-resistant staph. And one of the things I'd like to reemphasize is the idea that methicillin-resistant staph now comes in two flavors. You know, we used to think that this was something that stuck in the hospital, that out in the community, staph was something we could treat with any antibiotic we liked, and if it was just in the hospital that it was difficult. The bad news is now it's out in the community. Now, what turns out to be very interesting is what's out in the community are not escapee hospital strains. But in fact, the molecular epidemiology is showing that these are different staph strains. And as Dr. Souvenir points out, these are very aggressive strains. They can be nasty, but it's an organism we already know. So it's a bug we've got a lot of experience with, and it's something we're quite capable of handling. This means that there shouldn't be a lot of hysteria. And you've sort of read in the papers about people closing schools and this sort of nonsense. Doesn't do a darn bit of good. Because if you think about it, this is community methicillin-resistant staph. An analogy I like to use is this. Babies are born in the hospital, right? So that if you use that sort of logic, if you wanted to prevent babies, you would pass out contraception at the hospital. Well, babies don't start at the hospital. They just come to the hospital. Same for staph. You know, the community methicillin-resistant staph we're seeing is out in the community. We detect it in the hospital because that's where we look. And then Jeff had a number of very good points. You know, it truly is public health that's made the difference in our lives. If you look at human life expectancy, the single most important move we've probably made in life are two things. Two things. The two things we've done that are most important are this. We separated sewage from drinking water, that we drink clean water. And something that's made a huge difference in child life expectancy is we've educated women. And as women become more educated, child life expectancy increases. So I think it's public health that is still the most important thing we do. Things like the invention of antibiotics have actually made very little difference in human life expectancy. It's public health that truly does matter in what we do.
Dr. Alexander, already on our documentary, you've been talking about the emerging viruses, and of course you have dealt with it from a historical perspective. They've been around a long time, and we know more about them. You have the incredible credentials. You're an MD, and you're a PhD, and you are an associate professor at this time at the University of Chicago, dealing with, among other things, infectious diseases. As we continue our conversation, I would like to talk a little bit about the difference between viruses and bacteria. A lot of people don't know that differences, and I have been told by other experts in the field that we've known less about viruses than bacteria for a long time. Give us some contrasts and differences.
Boy, am I glad you asked that question. You know, this is an issue that I think many people get confused. Even a lot of educated people have a hard time sorting this out. The way to look at it is this. Really, bacteria are free-living organisms. They have everything they need to copy themselves. They can complete a full life cycle out in the world. In contrast, viruses are much more rudimentary. And viruses can't do anything without being inside a living cell. So it's kind of the difference between bacteria being a free-living organism. Viruses are almost like a set of blueprints. And blueprints aren't any good until you're in a factory. And the cell is the factory that you're in. So a virus kind of carries its own blueprint in and tells the factory, make more of me. So that's the difference biologically speaking. In terms of treatment and disease, antibiotics are things we can use to treat bacteria. And so if you come to me with, say, a strep throat, or a woman comes with a bladder infection, or a child with an ear infection, these are all bacterial processes that I can then treat with an antibiotic. In contrast, if you come to me with the common cold, which is caused by a virus, or influenza, right, the flu, these are viruses, and unfortunately in the year 2008, my treatments are much more limited. And so one of the challenges we face as physicians is trying to discern when you've got a viral infection versus a bacterial infection, so we know when we can use antibiotics and they'll benefit, versus, if we use antibiotic for a viral infection, all we're going to do is increase the likelihood of resistance.
I've had other physicians that talk about this, or experts in the field that you are, and if I understood them correctly, viruses, in a layman's term, they hide behind cells that are smaller. Aren't they harder to detect even before you treat that particular problem versus bacteria?
Well, this is exactly it. That, in bacteria, we culture them. If you, again, come to me with a strep throat, we stick a swab in the back of your throat, we plate it out on an agar plate, and we can see those bacteria grow. Our ability to detect viruses is much more limited. And that's also because viruses live in cells, and they need cells to grow. So you can't just plate them out on an agar dish and grow them.
In relation to that, too, viruses, we've known less about them than bacteria. Is that not correct? It's been more in the last 50 or 60 years that we've had an understanding of the different types and treatment as far as, I'm not speaking of not identifying them, but knowing more about them.
Right. Well, you figure that our understanding of bacteria really dates to Pasteur.
Right.
And, in the end of the 19th century. Our ability to even grow viruses didn't happen until the 1950s, until tissue culture was invented. And we can only grow in tissue culture a very small number of viruses. So you're absolutely correct. Our understanding of viruses is rudimentary compared to our understanding of bacteria.
And also, some viruses are very deadly and others aren't. The common cold, most people survive that. Would you take a little time to distinguish between the different types of viruses? I know we have a limited amount of time, but we hear about SARS, and we hear about AIDS, and all. Give us some distinction between the different types of viruses and what they do to the human body.
Well, viruses can infect just about any cell in the body. And the thing about viruses is they're very specific about the cells they infect. For instance, influenza virus only infects the lungs. HIV, on the other hand, can infect many cells, but what it targets is our cells in the immune system. So one of the things you can then say is, based on where viruses do their damage, we can sort of predict the kind of disease they cause. Influenza attacks the lungs, and therefore you cough and you have pneumonia. HIV attacks the immune system, and therefore when you wipe out the immune system, you make your patient susceptible to a variety of other infections. Herpes viruses affect neurons, and therefore you could expect that a herpes virus could cause infections in the brain and infections in peripheral nerves. And the kinds of diseases you see with herpes will reflect that sort of what we call viral tropism, where they grow.
And you've also talked a lot about the research that's being done about vaccinations. There's an awful lot of research, particularly about how to deal with HIV and then AIDS, as it belonging to AIDS. Today you had some real interesting comments at North Dakota College when you talked about that some of these, really vaccination may not be the path that is successful. Distinguish between the kind of research we should do in dealing with looking for answers through vaccinations.
So vaccination is something that we do that works very well much of the time. And if you think about many of the common childhood illnesses, measles, mumps, rubella, parents don't even know what these diseases look like anymore. We've been tremendously successful. Now, one of the things that makes our vaccination so successful is these are viruses that don't change very rapidly. And so it's like the target's not moving. If you compare that to viruses where we've not been successful, HIV and many of these emerging viruses I talked about earlier, these are viruses that change spontaneously and change very rapidly. And so it's a little bit like designing a weapon with an enemy that keeps changing. So where we have stable targets, we've been very successful.
That's the point I want to pursue a little bit further, and that is indicate that even if we have a vaccination and can attack and destroy certain viruses, what you just said, they can go through a change. So then it's a race for the scientists to keep up, is it not, with trying to find then another method of vaccination. The viruses seem to be very intelligent.
Oh, they are. And a good example for this is the flu virus.
Flu viruses, it turns out that the things you make your antibody to that protect you are on the outside of the flu virus. And so we make a flu vaccine and you get good antibodies against those proteins on the outside. So what flu does is every year changes those proteins a little bit like, the Carmen Sandiego thing with the kids, right? If you begin to recognize, if your immune system recognizes that virus, then next year the virus will change itself a little bit so it can reinfect you. And then what's really interesting is every 10 to 20 years, instead of making a small change, flu viruses will make a huge change. It's like a complete wardrobe change. And those are the years when we have influenza pandemics, where the number of cases globally may go up tenfold.
Yes, and we've seen that during your, I believe the 1920s was an example.
So it happens about every 20 years.
Yes. Now, in addition to that, a lot of people take antibiotics, and they've saved a lot of lives in different ways, but we hear a lot about the use of antibiotics, even if a particular individual's not taking them, that it can be a chain through all of the human race. Talk a little bit about, can we have some dangers with taking too many antibiotics and for future trying to contract other diseases or to try to prevent them?
Well, the battle against bacteria is a numbers game. Remember that you can set something in the neighborhood of 10 to the 7th bacteria on the head of a pin. And so that even if the rate of mutation is low, somewhere in your body when you've got an infection, there's going to be bacteria that are resistant to the antibiotic you're using. And so by constantly exposing people to antibiotics, you will select for resistant organisms. And then the problem becomes is if you do that enough, ultimately when somebody has an infection, it's going to be with a resistant organism. We're not going to be able to treat it. And then we're back like we were in the 1920s and 30s with no antibiotics.
Now, my point is with the antibiotics, does that have a connection then to what may happen to viruses in the world?
Well, I don't know, but I think the answer is no, in that we have very few antiviral drugs available to us. Compared to antibiotics, where there are books and books full of different antibiotics we have, there's really only about a handful of antiviral drugs. Now, there's a large collection of HIV drugs, but for the other viruses, there's really only about a handful. And so far, our experience is much more limited. We do see resistance in viruses, but it doesn't seem to be the problem yet that we have with bacterial drugs.
So we must make a very clear distinction for our audience between antibiotics for bacterial problems versus the few treatments we have with viral drugs.
This is exactly it, that the antibiotics that we have for bacteria don't work against viruses, and the antiviral drugs we have for viruses don't work for bacteria. And this is why it's very important when you go to the doctor and your doctor says to you, we've got to determine whether this is viral or bacteria. That's in your best interest.
I guess I ask you to look into the future. You're an incredible person with great knowledge, but as we develop, if we do, many more viral treatments, can the day come that it'll be like the antibiotics that they would be a counter to having too many of those? I'm
sure it could happen. That again, this is just a principle of natural selection. Yeah. This is Charlie Darwin all over again. That if you apply a selective pressure, be it an antiviral or an antibiotic, an organism will eventually find its way around it. I just hope that as time goes on, we continue to get smarter. But it sounds like the viral problems of the virus are probably more aggressive and more intelligent than the bacteria. Well, again, it's a numbers game. Yes. When you have a viral infection, you've got an awful lot of virus inside you. Yes, you do. And so, the one difference is that, your immune system is also helping you here. And in the end, one of the things you have to remember is that antibiotics and antivirals are important, but what they do is hold bacteria and viruses at bay. It's your immune system that helps you win the war. Something else you do that's really fascinating to me, and that is you talk about, in relation to viruses, some of them are actually that we have a greater resistance to them, or you cannot pass them on. HIV is an example where, would you speak to that, where because you're in the room with someone who has that, it's not the same as a virus with a cold or flu? Well, this is it. Viruses vary tremendously in infectivity. The most infectious viruses spread through your respiratory tract. Probably the most infectious virus known is measles. Right. If I had measles right now and you're susceptible, I'm afraid you've got measles. Yeah. Now we compare that with other viruses that are not spread effectively, and HIV is a very good example. You wouldn't look at the world pandemic of HIV and go, wait a minute, this is not a very infectious virus. But when you think about it, the way HIV is transmitted is either you have sex with somebody, you share needles with somebody, or you give birth to them. You can live with somebody all your life, and if you're not doing those three things, you're not at risk with HIV. You can work with somebody every day of your career. And so it's very important that people understand that things like HIV don't pose a risk to the community, provided you're not having sex with somebody, sharing needles with them, or giving birth to them.
Unlike colds and flus.
Right. Colds and flus, there we're gonna share. You know, you sneeze on your hand, you shake hands with somebody, you've passed on the gift of influenza.
And my final question to you, again, is a futurism question, is are you optimistic about the future in the world of science and combating viruses?
Tremendously optimistic. Now, that said, viruses like HIV have turned out to be a bigger battle than we ever planned. And if HIV has done one good thing, it's taught us a lot about how the immune system works. But we've got a lot of work to do. So while I am optimistic, the human spirit is a marvelous thing and human ingenuity is a great thing, it's not going to be an easy battle. It's going to take money, it's going to take persistence, and most of all, a lot of commitment.
I want to thank you so much, Dr. Alexander. You are doing wonderful work. In addition, you're teaching at the University of Chicago. I know you've received millions of dollars in grants to do research, and good luck in your work. And thanks for being with us.
It's a pleasure. Thanks very much, Tony.
I thank you for joining us in this one-hour documentary that was dealing with emerging viral diseases, a world crisis, under the main heading, A World in Crisis, A Search for Solutions. Please join us on our third documentary, which will be with you at a later date. I want to say, ladies and gentlemen, that you've been watching for the past hour a very important discussion by some very prominent experts on emerging viral diseases, a world crisis. And as you are watching, you know that Dr. Kenneth Alexander, who holds an MD degree as well as a PhD and is a professor at the University of Chicago, has really enlightened you about infectious diseases and dealing with such things as SARS and AIDS and the Hantavirus. And we've talked about on this documentary how that particular issue of virus is something we've not known a lot about except back to the 1940s. It's much more difficult to deal with than bacteria. You also have heard from Dr. David Souvenir, who is an infectious disease specialist and also an MD. Now we're going to take you to our town hall meeting, and our good citizens here are going to respond to this documentary they did last week for you who have viewed. And our topic, of course, is Earth in Crisis, A Search for Solutions. And of those 5 that we are discussing, of course, today, it deals with emerging viral diseases. May I say to those in the audience that we appreciate, again, having you here. And you're wonderful to take this Saturday, that when we're taping this, away from your other duties to inform and engage in discussion with our viewers. And another couple of comments from previous shows that I've done with experts from Spokane on viruses. They tell me that, one, as I've already said, that we've not known a lot about that as we have some other diseases. And the viruses are very small. They're quite clever. They hide behind the cells. And the other point I would make with you is that as there's so many thousands of types of viruses, and so when some of these emerge and are very infectious, we see influenza sometimes being very dangerous. And I believe it was in the 1920s there was a influenza that killed thousands and thousands of people in our country, and before some of the treatments we have now. But there's a question here of global travel. And so we're not isolated villages. And so when something serious happens, it becomes a global problem, including the example of HIV and AIDS, turning into AIDS. And we really learned about that in the early 1980s, and of course it became an epidemic, and it's been an incredible problem in Africa. So I'd like all you good people to respond to my first question. Then Erna Reinhardt, who's with us, she has been a panelist on our North College TV Public Forum for the last 5 years, and my dear friend is in the audience, Janelle Burke. And Janelle, you was with me for like 33 years as we bring this series to a close, and what a professional you are. And you can feel free to ask a question as well as respond to these issues. But my question is this: how serious is this problem? And how do we cope with it? Does sometimes our addressing get in the way of public policy or political issues or funding? So that's kind of a wide open question. Who wishes to go first? Janelle Burke.
I'll go first, Tony. It is one of the things that I think is a very important issue, and it's going to become more important. And part of the reason is because, as you indicated, the global travel, but also part of the reason is because we've changed our patterns of lifestyle. And so as these kinds of things begin to emerge, it's going to be a continuing issue. There are the issues with children as to whether they receive certain immunizations. There are the issues with older people as to whether they can withstand certain kinds of diseases. And so it's going to become an increasing problem throughout the world, I think.
Janelle, can I follow up with you on that? And that is, as you said, as we travel, and what advice would you have the public? They might say, well, there's a breakout of something in Asia or something. I'm not going to worry about it. First of all, that would be selfish not to be concerned about other people. But secondly, what advice you have? We're not isolated, and so they better worry about it, because next week it may be in our country also.
That's very true, Tony. And the other thing is, we all go now to the malls. We all go to the grocery stores. We're not nearly as remote and isolated as we were at one time.
And when you're on an airplane and you're in that cabin closed in, the young man, there was the issue of Atlanta going to Europe, and they thought he had the most contagious form of tuberculosis. So, in other words, if you'd go ahead and elaborate, we can't just avoid or escape what's happening to others.
No, and people come and go from all areas of the U.S. now, and as well as other parts of the world. And so when something emerges in another place, it very likely could come here as well, and we would be rubbing shoulders with it without even recognizing that.
Okay. Who else wishes to respond next?
I'm Bob Bennett. I'm the Executive Director of the Human Rights Education Institute.
And I'd have to add, you also the former president of North College, as well as some other colleges.
Thank you very much. I read a book called 1491, and it was about what happened to the Indian population as a result of virus coming here. We talk about one nation killing off so many people. If you really want to look at the numbers and you look historically at what's happened with human population, you realize that the great masses of people that lost their lives in many cases were due to a virus or a bug of some kind. So I think it's always been this war with the bugs that we've had. I think there's another side to this thing. On one hand, I think we have to be very conscious, and I frankly don't like to ride on airplanes simply because of what you had said earlier. But there's another side, and we know that the pharmaceutical companies have made huge amounts of money trying to scare us to death with respect to some kind of a potential disease. So as we talk about the virus and the threat of the virus, and recognizing that, in fact, we have to deal with homosexuality and other taboo subjects in order to talk about the virus, that's difficult, I think we have to understand that there's a lot of money to be made in this scare that we face. So as we talk about the ugliness of the virus and the potential threat, I think there's the other side in terms of what people are doing to make money with this threat. So I throw that out for some thought and consideration.
Kay is next, and then Ron will be next, then Kay Nelson.
I'm Kay Nelson. I'm a former faculty member from North Idaho College. As I was sitting here listening and contemplating, this subject, I really wish that I had my son, who's a medical doctor, and my daughter, who is a pharmacist here, to give some expert advice to all of us. But anyway, I'm going to give it my best shot. What we humans, we want to always feel good at the very top. And so we are willing to pay almost anything and do anything to be able to achieve that goal. So consequently is that the pharmaceuticals, yes, they will produce the next set of pills that is going to make us all feel good. Unfortunately, it's a catch-22. We have scientific proof that just as soon as we conquer one virus, then that virus has the ability to mute. And that mutant then gets right at us in another fashion. So hopefully maybe some of the other panel members can touch on that.
Ron
Johnson, I'm a retired airline pilot. One of our problems is that we tend to be reactive rather than proactive. For instance, take mad cow disease. We handle this by recalls of foodstuffs, either produce in some cases or in the case of cattle. We recall meat. We've had a lot of those in the last year. I understand that many of the inspectors were taken out of the plants. So government has a role to play in this. If we put these inspectors back in, they've loosened the restrictions on downer cattle, as I understand it. And once again, we add to the problem, and government does have a role to play in this. It cuts across the entire spectrum. Capitalism, because the farmer wants to make as much money from these cattle, and he has that downer cattle, and he realizes he's going to lose money on it, so capitalism plays a part in this. And other viruses, they span the spectrum from the economic to sex education, as has been mentioned earlier. We have to have a proactive solution to these problems, not reactive. Treatment of a disease is reactive, and we have to get ahead of the curve.
Let's follow up that with you on that, Ron. If you go back to the Black Plague in Europe, just think about how much it devastated the population. But the first reaction to that was, I hate to use the word ignorance, but it was ignorance and mystifying and all, and they blamed the wrong things and didn't help the problem. And then when they found out the problem with the rats and they were going everywhere, so aren't you saying that too? That could be in current times, people should be very concerned about talking about being conspiracies and all those kind of things. If you're not going to really try, and that's what scientists are so good at, saying, no, let's get to the cause of the problem. So how would you respond to follow up on what you said, that we need to be wise if we're going to really address some of these threats that we have?
Well, I think it was mentioned earlier about vaccinations. These are proactive. Vaccinations get ahead of the curve, whether it's for older people taking their annual flu vaccine or in the case of pneumonia, as you were mentioned in your physical, as you had mentioned about your physical. These are things that we should do and should be supportive of those. It goes the gamut. It's not necessarily a virus, but people are against known treatments for tooth decay. They don't want fluoride in their water. It's been proven time and time again that this avoids tooth decay. If we don't put it on in the water, we have to put it on, I don't know the term, topically, I guess, is what my dentist does for me. So I don't know if that answers your question or not.
Yeah, it does. That's the kind of thing that I was trying to get at.
That's what we need to do. We need to take these steps that we know can have some effect and take them when we know that they're going to be effective.
Like it's proactive, preventive.
Hello, my name is Amanda. I'm a graphic design student at NIC.
Can I interrupt to say, Amanda, on the future shows, we're going to show some of your work that you did for our series.
Those, yes.
We thank you very much for that, Amanda.
Thank you. Being a parent of younger children, I think when you take your child into the pediatrician needs to be a little bit more aggressive with the parents. Most of the parents that I see beg the pediatrician for antibiotics when it's just a cold, and that doesn't help the situation at all.
And Amanda, what you're saying too, ties in with Ron Johnson, sometimes if some individuals make certain decisions and that prevails, but it impacts other people that didn't. So we don't make these decisions in isolation. It affects others.
Well, you were saying before that viruses are much more difficult to treat than bacteria. So there's really no way to treat a virus with antibiotics.
Right.
And the pediatricians, just time and time again, I've seen it. They hand out the prescriptions.
And that's for bacteria rather than...
Yes, and they hand out the prescriptions to the parents because the parents just beg for the prescription.
So are you saying that physicians can give in sometimes when they should?
They do, I think, sometimes because of the parents.
Yeah. Let me follow up on another thing, because that really mentioned this was on, I believe, NBC a couple of weeks ago, and they were having a debate, and it's fine for you to have a debate too, and they had some parents on there and even some medical people who said that we want either a vaccination or a pill for everything, and so they'd come up with this technique of to please children who really weren't very ill, they would give them sugar pills. Yes, right. But then there was another counter-argument saying, oh my goodness, you're training this child that when they grow up, they'll have to have a pill for everything, and it won't be, it'll be a very powerful medicine. So is that also part of our problem?
Catch-22 that Kay was talking about earlier. I also believe that over hand washing is too much. You can't build up an immunity if you're over washing, taking all the bacteria off your hands.
So is there, and you could also wash your hands too few times, so?
Yes, catch-22 again.
I shouldn't probably say this on the air, but I will say this before we move on. I really appreciate Amanda doing that. And I guess I'm more critical of men than women. When I go to the restroom, I would never, ever go to the restroom without washing my hands. And I believe that sometimes that about half of men don't wash their hands to leave the bathroom. So it's kind of risky to shake hands with men. I would make that point. Okay, who else we should, yeah.
Kind of a follow-up comment. I really strongly believe that education is really very, very paramount. Yes, the concept of being proactive rather than reactive is very good. Unfortunately, we do have occurrences within our human society that causes us to totally react because we're not prepared for it. We're not educated to it. When it does happen, then we humans have an incredible ability to be able to use our brains and to do immediate medical research to be able to figure out what in the wide world is going on. And so when I look backward in time and see the advent of some of our drugs that we have produced, starting clear from years ago, sulfa drugs, it's phenomenal. And I'm not sure why this is always true, but we will get there someday. But we can't hope that our doctors are going to be our creator and to be able to make us feel wonderful and good every single time. It can't happen.
In spite of the gloominess of some of our discussion about viruses, yet there's been such medical breakthroughs that we live longer than we used to. There are thousands of people now in America that are over 100 years old. So there's also some things being done that have been very constructive and positive.
I want to comment.
Introduce yourself again.
I'm sorry. I'm Lauren Burke, and I'm a retired banker. One of the things the agriculture industry does, especially cattle and chickens, all kinds of fowl, have in the past have used a lot of antibiotics in the feed so that the animals don't become ill, so they can sell them. And I think we've tried to get away from doing that, but I'm not sure it's completely done. But that builds up a reaction, a resistance in everyone who eats the meat. And we hear about mercury in fish. Well, that's a byproduct of coal-fired power plants and that sort of thing. So there are a lot of things that we need to look at that could increase resistance to these, the use of these antibiotics.
It's a really good point.
Tony, you said I could ask a question.
Sure.
My question is, how much do you think we should be encouraging research as being proactive? Where and who should encourage research? Should it be a government function? Should it be a private industry function? Who should be involved in the research process?
That's a great
Does anybody
question.
have a thought on that one? Front row, you've been quiet. Philip Van, graphic design instructor at North Idaho College. I think there's a taboo subject, and let's talk about it. It's about AIDS. It's a worldwide epidemic, and I think everybody should make an effort. I think the policymaker, it's really interesting in the United States or other country, entertainers are creating a lot of funding, but I don't see it's a very difficult subject to talk about. And where's the funding? Where's it coming from? Are we putting more funding into funding new fuel? Are we putting funding into AIDS? Are we looking at that solution? And I don't have an answer, but I think that's a global epidemic. We have very good researchers in the United States, in Europe, who have access to medicine, while in Africa, they do not have access. So is it a global issue? Are we sharing this with those other people? Are you sharing that knowledge? Or AIDS is only going to find a solution in the United States or in Europe. Therefore, the pharmaceutical company will sell the product. So I'm not sure where the solution is, but I would like to see government, policymaker, joining with, right now, entertainment people that try to fundraise money to help to find a solution for that specific virus.
Philippe, step one is what you did. You asked the question first. That's always the question comes first.
Hi, Jeff Jeske. I'm a small-time entrepreneur, part-time, thinker, and a part-time writer. Today I'm a little bit of a talker.
A little bit of Renaissance.
I'm going to be Mr. Happy here, and boy, I'm going to make kids happy, and I'm going to touch in with what Kay and Amanda were talking about, and I've thought about this for years, so I'll get to it, but let's start with the chicken, because we're all kind of freaked out about antibiotics in the chicken or getting the chicken disease, the avian flu, and gosh, what about that? Well, anybody that raises chickens knows they get their immune system by pecking in their own stuff. In other words, they're sort of eating their own, well, dirt. My theory here, too, is about this thing about guys that do wash and maybe they shouldn't wash so much. It just goes right to the heart of it. People, one, viruses have been here since at least the bubonic plague and before. They're going to continue to be here because we know that everything that's green and grows is not necessarily good, but it still grows. So, mothers, let the kids eat a little bit of dirt. I'm not saying send them to the chicken coop because that would be foolish, but let kids get a little dirty in order that we too can build up a natural immune system to the things we're told, at least from the way back 2004, I believe it was, National Geographic did that article with the people down at the Center for Disease Control. Hey, every 20 years or generation or so, some new virus pops up or it mutates and it goes another direction. Yes, to answer Janelle's question, you're darn right I'll pay taxpayer dollars, whoever has to push somebody in gear to continue to stay on top of this, because it's not going to go away. And if we intend to live as long as we can in this world, you're right. We do have the technology, put it to work, and some of it is simple. Let the kids get a little dirty on occasion, Mom.
Well, Ron wants to answer that one, and then Ernie, you ask a question.
Yeah, he made a statement that sounds good in a way and works within a relatively small area. But he said, let the kids eat the dirt. Well, that might be good for biological problems, but in this area, in our viewing area, we have a lot of lead, which is a tangential issue to this, but it is disease. And you do not develop a tolerance by eating dirt that contains lead. So, whereas this is another issue, it is something that has to be considered. We have to be proactive in that regard also.
So I guess Jeff might want to withdraw that statement about certain locations.
Well, sure, Ron, sure, and that was my metaphor, not just realistically with the chicken coop. Of course, we have to be aware of, what are the other polluting things we're doing to this earth? And yes, if we're going to spread lead, or so to speak, or chicken feces around, we're not going to naturally be able to send the kids out to eat dirt to build up an immune system so that we can fight off the viruses that are already here. People, got to keep the chickens in the chicken coop, which means put the lead back where it belongs, in a battery someplace, but not in the water, not in the air, and not in the dirt where kids play.
Amanda wants to say something, I think.
Isn't this how Mother Nature controls the population with disease? It is very gloomy outlook, but that's just how it is.
Now, Ernie, you have Bob Bennett wants to say something then.
Well, when we got into this war with Iraq, we were told that there were weapons of mass destruction. And then we were also told that there was all this germ warfare. We were told that in World War I. We were told that even in World War II and somewhat. So there's always been this great fear of the unknown in terms of how do people wrestle with this virus or the bugs. And I do think it's interesting that now nations have taken that concept and they have said, we can pose that as a threat, and we will threaten your very existence. We don't have to have bombs anymore. We'll just spread the bugs over here or get the virus over here. So for that reason, I guess I would agree with Jeff. I think that the government does have to be concerned about the possibility of those kinds of things happening, particularly when we talk about all the terrorists and so forth. But I sometimes think that we are our own worst enemy in terms of saying those people are going to spread the virus when, in fact, they're just as knowledgeable as we, and why would they want to let loose this awful thing? You know, the winds go both ways, so it could be very disastrous. I do think, however, that we cannot ignore it, and because it is so difficult to understand, it comes right back to one of the other comments about education. Science needs to be stressed a great deal more with respect to how we understand that thought.
Ernie, you have a question? Go. How about 5 minutes?
I do. I want to shift gears a little bit and talk about something very positive. And I am a huge fan of Rotary International, and I know Kay Nelson is a former Rotary president, and I know that the Spokane Rotary Clubs and the Coeur d'Alene Clubs, all of the Rotary Clubs throughout the country have done some wonderful, phenomenal things globally. And I'm going to kind of put Kay on the spot to have him share with us for a few minutes just some of the things that Rotary International has done to help and assist developing countries on these issues.
In about 1985-86, Rotary International took on a project to try to eradicate polio from the face of the earth. And up to this point, this has been extremely successful. There's about 5 or 6 countries in the world where this has not taken place. Those 5 or 6 countries have a religious point of view that says we will not accept any help from any of the Western countries or anybody else. And so they choose not to do that. So when the question comes around, well, who should promote the fight against the viruses? To me, it's a global issue. And it's not just simply a government issue. I think we all can agree that any time that we put the government at work, then it gets screwed up. But I think that our government can, and jolly well can then, as a collective unit, give monies to private individuals, to research centers, universities, the process of continuing this quest.
Quickly, what's the difference role for government and the private sector in doing research on viruses? They're both partners in this?
Well, I'm not so sure I agree with Kay that the government always screws things up. I tend to look at government as being there for us, and we need them badly. We need to be more responsible. And I'm not sure that private industry always is the answer with respect because of the profit motive. I think there are sometimes they will do things that are maybe not in our best interest. But I do think that international clubs such as Rotary have done wonderful, wonderful things for individuals, and it's exposed complete nations to the possibility that science can make a difference with respect to the health of the people.
Well, I have to say to you and the audience, this town hall meeting, you're very impressive. And last week you were here, and the good news is you're going to be coming back as we do this series. I'm very excited about this series of documentaries. One of my most prized projects I've done in 36 and a half years with PBS, and I really think you're very articulate, and this is such a great way to end the documentary after the experts that have come across the country to us to deal with this, to have citizen reaction, and your backgrounds are very varied, which helps a lot. And I kind of rejoice in the fact when you have a little disagreement with one another, that's called democracy, and so free speech. Last time I checked, the First Amendment is still alive, and we want it to be that way. Again, thank you very much, and ladies and gentlemen, it's been a pleasure to be with you today. And our third documentary, which is next week, we're going to be talking about contaminated products. And we have a great expert on that documentary from Chicago, and of course we'll have our town hall meeting too. So I hope you'll be with us again next week at our third documentary. Until then, please have a good week. I am Tony Stewart.